You're listening to the podcast between doctors and friends. Welcome to another week of Between Doctors and Friends. Something special about today is that it's also a new year. We have here Dr. Ray, an OB-GYN doctor, and Dr. Foz, a primary care doctor. Any little wins that you had in the last week? Let's start with Dr. Ray.
At work? No, it was the end of the year, so a lot of things that just needed to be wrapped up as far as accounting and bookkeeping for me, because I do that at the job. But I did have two deliveries this week that were on patients that were some of my long-term patients, so that just made me really happy to conclude their pregnancy. I think I also did a Christmas Day delivery, and so that was really nice. It was for a fellow physician. I was not working Christmas. I had it off this year, and we opened our presents, and then I got a text message from this fellow physician who was my patient, and she happened to go into labor, and I went to go deliver her, and it was perfect and beautiful and everything. So I've just had a couple of really nice deliveries this week. But that's about it. We're slow in the office because we have some employees who are using up their PTO time during this holiday season, and a lot of patients who are off on vacations and spending time with their family as well. So it was just a pretty nice and normal week with just all the end of the year accounting and figures that were thrown in there.
Wow.
That's so nice that you went in to deliver your colleague's patient's baby, even though you weren't on call.
Yeah, we do that for, quite a few of our patients, definitely our colleagues, our doctors and nurses and other hospital employees. They come to you for a reason. And so I feel honored out of all the doctors that they have there at the hospital to choose for whatever reason. They came to me to deliver them. And so as much as possible, if I'm available, I will deliver them. This particular colleague, this was her third baby, so I delivered her first one. Her second baby, she went into labor when I arrived at my son's college to move him in freshman year in his dorm. And we had just gotten to the dorm and we're just about to start all the move in, and it's out of town. And she texted me and I felt so bad, but I told her, I'm so sorry. I'm out of town doing my son's move-in. There's absolutely no way I can get back in time. And then I would have to abandon my family and then stress out about moving him in. And this was supposed to be a special day for him and a special day for me as well with the move-in, that I just couldn't leave. And she was very understandable. So this third time around, when it came on Christmas Day, I was home, and, other than it being Christmas, there was no reason that I couldn't go in. And so, it just worked out really nice. And when I can be there for my patients and for my colleagues like that, I always want to be able to do that. So.
Yeah, that's so nice. That's that professional courtesy that I've alluded to in the past. That, I think that's super cool. And I'm so glad. And she had a Christmas baby. How fun.
She did. Yeah. I
didn't, baby.
Yeah. I didn't, they hadn't decided on a name yet. So I was like, you have to give it a Christmas, name, because.
Well, she named it Dr. Ray.
No, it was a boy. So it could have been Ray. But I told her, because the time was 12:25 p.m. on 12/25.
Wow.
Aww.
So, we were all like, you have to give it some kind of Christmas name, name it Noel or Christopher, something like that, something with, a holiday spirit to it or something. So, but they hadn't decided on a name yet. And so I haven't seen her yet to find out what they actually named the little Christmas baby.
Wow. I would have named him
Just get straight to
Mariah.
the point. Yeah, name him Jesus. Straight to the point.
If
Straight to the point.
yeah,
What's the male version of Mariah?
if she was,
Myron.
yeah,
There you
if she was maybe a Hispanic origin, then yeah,
Uh-huh.
Jesus would be perfect. But they're not, so it'd be very odd, especially with what their background is to have a Jesus.
That's so funny. That's a poor baby though. As a December celebrant, we only get one celebration.
Yeah.
Right? I even feel bad for the ones after, between like December 25 and Jan 1. Talk
Right.
Yeah, totally.
about being
Lost
Right.
in the fray.
Dr. Foss, how was your week?
It's been okay. I've actually been off work and
Wow.
spending a lot of my time doing all the continuing medical education time that I've been needing to do. So I've been studying like mad.
Wah, wah.
This is a new thing for me. I'm usually really, really good about that, but I've just been so busy. So
Wow. And for the
Yeah.
listeners out there, I don't even know a time when Dr. Foss took so many days off. Except when we went to
I don't
Hawaii.
remember. I took 2 days off for that. 2 days.
All right. So, we will, I have some kind of, some questions that was just brewing in my mind over the holidays that I would ask you. So these questions are probably like just all over the place. Well, first of all, season 2 of The Pit is returning at the end of this week. Do any of you watch it? And what's your comment?
I did watch it, and I thought it was very well done. Of course, Noah Wiley, for women of a certain age, he was, a big crush that most of us had. And growing up on ER, we all absolutely loved that show and loved his character. So for me, when I'm watching it, I feel like it's Dr. John Carter just all grown up, but he just calls himself a different name. But I think the series is very well done. Of course, there's a lot of drama. Every ER show has to have a delivery scene in there where some pregnant woman comes in and has a baby in the ER, and those are always 100% wrong. Everything about it from start to finish is just awfully mismanaged in every ER episode, in every other medical show as well. They never get OB right. So that's the only criticism that I have with that show is the OB scene. But otherwise, in all my doctor friends and doctor groups, everyone seems to think that it's very well written, very accurate as far as a life of a doctor in the emergency room.
Wow.
Where did they screw up with the OB stuff?
Yeah.
Oh, if I remember correctly, because I haven't seen it since it was on, it was a shoulder dystocia situation where the baby's anterior shoulder gets stuck behind the pubic bone. And there are certain manipulations that you need to do, and they again, it's drama, so they took their time, but really, like, you have maybe 90 seconds to 2 minutes to get that baby out. And I think it lasted like 10 minutes the whole time. And then they stopped to talk about it a little bit. And then they called people to come in to the room and started calling for help. And the whole time I'm going like, oh my God, that head is still stuck. That's still, it just took way too long, and they didn't make it seem as urgent as it needed to. And then second, women should not be having babies in the ER unless it's a hospital that does not have OB services. Women are brought in through a separate maternity entrance, taken straight to labor and delivery. Or if they end up mistakenly in the ER, they call us to come down immediately. And there's nothing that we're doing that we are not running down there to help this patient. If for some reason all the doctors are busy, you would have still nursing staff that went down there. and the nursing staff have attended enough deliveries and can help and assist in the delivery a lot more accurately than what they portrayed. So most of the time, any pregnant woman, any mother baby story is meant to be emotional. So that anytime a pregnant woman comes in on the TV show or she's in labor having a baby, they're going to make it so that something happens, right? The baby's going to die or the mom's going to die because that's the drama, that's the emotion, that's what's going to get the viewer all involved in this, and, most of the shows, Grey's Anatomy, ER, they've all had multiple, pregnant women come in who have died or their babies have died or something has happened with that. But that's sort of the emotion of it all, the drama of it all. So, so if it wasn't that, it wouldn't be a good TV show. But from the live point of view, from the actual person who's done this many times, I'm going like, oh my God, this is just so inaccurate. Why don't these shows hire an OB-GYN and just have them, and they never have, and they're always calling, they make the OB-GYNs look bad too, because they're always calling them, get OB down here. And then they'll be like, oh, OB's doing this, or OB says they can't come, or OB says they, to go ahead and
They
do
can't
this,
come.
or whatever it is, they make it seem like we're just not available, like we're not there to help. So it's very frustrating, or they'll say, or the OB will come down. And I think this one in this show too, the OB came down like with attitude, like, I was, doing this and da da da, and what do you guys need down here, and that's just not how it is. So
No,
I'm recording my podcast.
It's funny. I remember in a few instances that I've been involved in the care of a shoulder dystocia, it was over before, and that was a long time. It was over before I even knew it started. So I hear you on that. Like, you got to move fast.
Yeah.
So are you saying that the OB-GYN department is always close to the ER?
No, not
Okay.
necessarily, but I know majority of hospitals will have a separate labor entrance for maternity patients to come where they're taken directly onto the labor floor. So they don't go through the regular emergency room. They don't go in there, they're not standing next to somebody who's complaining of chest pain or somebody who, got a cut on their finger and waiting their turn in line to be like, I'm having a baby. So most hospitals have a designated entrance for the labor and delivery where they come and they enter and they go in there and they're taken up to the labor and delivery center to be handled by, labor and delivery nurses and the obstetricians who are there. So they don't go through a normal.
Wow.
Yeah, I don't remember. The hospitals that I have been affiliated with in the past, we didn't have a separate thing, but there was like a fast track for them. Like, if it was, you come in and you're pregnant, automatically it's a different, this is where you go instead.
Wow.
Yeah.
Different, because it's different. There's a hand up.
Didn't know that.
Hand.
Hey, I chill.
Hello.
Go ahead.
Hello. I just like to introduce myself. What's up, Happy? Hey, Auntie. Hello, doctors. I'm
Hello.
a RN. 42 years in pediatrics, most of that in the ICUs, transport team, the whole shebang. So I've been wanting to come to this podcast for a long time, but I always forget about it. So I just wanted to meet you guys and let you know who I am, and I'm listening. I don't watch any medical shows. Back when Saint Elsewhere first came out, and everybody was like, "Oh, that's such a good show." I hate medical shows. Okay.
You know what? Me too. I feel the same way.
Wait, why? So we have Dr. Ray who watches medical shows, and
I love
Foz
them.
at Night Chill.
You
Why?
do?
Why do you hate
I
it?
do.
Okay, Dr. Foz, why do you hate it?
I just feel like I've done enough of that through the rest of my day. I don't need any more of it.
Thank you, Dr. Fox. Like, I do this in real life. I do not want to see nothing on TV about it, okay?
And then also, it's like you were saying, Dr. Ray, like there's drama behind it. They have to make it so sexy.
Mm-hmm.
There's nothing that I do on a daily basis that's even remotely sort of in the realm of sexy. So, like, it's sort of funny to me. That's why it doesn't hold much interest for me.
That's what I'm learning.
But to be fair, I'm not generally a series watcher anyway, so, I didn't, so part of it is that.
There goes my idea of watching The Pitt and breaking it down every week.
Please, please.
Different if it's assigned work. If it's an assignment, I can do it.
I'll do that with you. I find, I don't know what it is, but I find them entertaining, but I also feel like it's a comfort zone for me because I'm just so comfortable in a hospital environment that when I turn it on TV, I'm just like, oh, a hospital. Yeah, that I'm comfortable or something. And I just feel like I can understand more or identify more, but definitely I'll sit there and be like, this is not how it is. This is not how it is. Right. My family will sometimes come in. I don't know if you guys ever watch the show called The Midwife, but that's all about just delivering babies. And every episode they're delivering 4 or 5 babies. And I'll just sit there and watch them, and the kids will come in and be like, what are you doing? I'm like, oh, I'm watching a TV show about delivering babies. And they're like, why? This is like what you do. Like, why are you watching it? Like, this sounds so, just like you guys. Like, yeah, like if I was a computer programmer all day, I wouldn't come home and watch a TV show about computer programming. Like that's, so, but to me, I don't know. I find it interesting. I like the stories behind it. I think I feel empathetic. I understand, a lot of things about it entertain me. It almost feels like they're not really medical shows because there's just so much drama around them. It's more relationship shows. It's more stories about the people and everything.
Yeah, well, that makes sense, Dr. I understand that, but I'm always sitting there like, yeah, that ET tube's gonna fall out. This is definitely not.
Oh yeah,
they want the actor's face to show, so they have a little piece of tape on the tube, on the side. I'm like,
I'm very critical too.
Oh, I bet you. I think it's just, Dr. Ray, you're just more easygoing than I am. You know what I think is so funny is whenever, I don't care what it is, it's often in movie scenes, whenever they do CPR on somebody, it cracks me up.
Oh, it's awful.
Why? Awful. It's like not even, real CPR is deep and hard and painful. Like you can't do it on somebody who is awake and alert and not injure them and possibly kill them. But like CPR in the movies, they just kind of, it's so obviously fake. I just feel like they could film it better. It just looks bad.
You need to be higher up on the bed. Your arms need to be straight and almost like your elbows locked. But they have it sort of like chest level, and their arms are kind of straight in front of them, and they're just sort of pushing down on it. It's
they look
terrible.
Like they're messing with a squeaky toy.
It's terrible, and I'll watch it and be like, it's so inaccurate. But then I'm just like involved in the drama of it, really.
Maybe AI changed that, where we see the actual depth of the movement. But of course, you can't do it on an actor, so I give them some leeway with things they really can't replicate. As far as that, I just don't like medical shows. When I was off duty, I was off duty, and that meant I didn't want to see anything about a sick person on TV. I just didn't. That's just how it is for me.
Well, as a friend, all I do is think about, you guys when I watch these shows. So,
oh no.
Is this what they do? And now you're telling me, I guess I can't learn it from the show. Huh?
No.
Oh yeah, don't learn medicine from the show.
Wow.
Yeah, learn it from Google.
Well, you know what?
Totally.
Don't do that either.
well, that leads me to my other, wacky question here. I kind of came up with this, how do you gently redirect someone who's convinced Google is right?
It's a hard one. Sometimes you can't.
Yeah.
Sometimes you just can't.
I think most doctors have reached their breaking point with trying to convince patients that, vaccines are not harmful and certain situations are not what they appear to be. That, I just try to listen to them. If they come in and they say, I think I have X disease, and I'll say, okay, well, tell me your symptoms or what's happening, and they'll tell me all this stuff, and I'll say, that actually does not sound like X. It sounds maybe more like you're having Y going on. And they'll say, well, this is all the stuff from Google, and this is everything that, that they say, or I read about it, or I saw a TikTok or whatever. And then I'll try and explain it to them the best I can that, what, that's not accurate. This is why it's not accurate. This is why I think you have, a different situation, or you don't have a situation at all. And I'll try and tell them. And majority of the time they'll listen and they'll be like, okay, that makes sense. I understand that. But sometimes they'll be like, no, I really think I have this and I need XYZ to be done. And then I'll just simply tell them that, I'm not able to do that for them. And then that's it. I think a lot of us have sort of said, well, I'm just going to present what I think it is and what I think you should do. If you don't want to agree with that, then that's your prerogative, and then we can just part ways, instead of arguing with them, instead of like trying to convince them that, this is what you need to do. No, that's wrong. And I'm going to argue with you and tell you that this is wrong. I think a lot of pediatricians have this battle on a daily basis with the vaccines. A patient will come in and say, you know what, I don't want to have my child vaccinated. The pediatrician can say, okay, what are your concerns? And these are what I recommend and what my concern is. And if the parent says, okay, no, I'm still not going to do it, then the pediatrician's like, okay, well, just write, you just document in your chart that you refuse, and that's it. That's all you can do.
There you go.
Have a question. It's hard. It depends on, like, the topic. I think it's one thing if you agree to disagree on certain points like vaccinations. And I think that especially in pediatrics, that's a whole other thing, because some pediatricians will dismiss the patients from the practice if they won't vaccinate their child.
Oh, really?
Oh, yeah. That's not considered like the first line kind of thing, but it's not outside of the scope of, I think the American Academy of Pediatrics says, you can do that if it's like a last resort. Obviously we want to work with everybody. We want to bring everybody in the fold, and we also want to give everybody the best medical care you can. But in certain circumstances, sometimes that can be really hazardous. Like, you can't have a young child who's never been vaccinated sitting in a waiting room with all of your newborns who are coming in for the first time, and that kid is sick and might have measles or whatever, So you have to think about protecting the other patients. For me, as somebody who deals with more average chronic illnesses, sometimes patients don't agree with your treatment plans. Like, hey, you have diabetes that's way out of control. You need to fix this. Or, hey, your hypertension's really bad. You need to fix this. And they'll just like, I don't agree with that. I'm like, okay. And then I have to caution you that, you could die, or you could be gravely disabled if something happens, if you choose not to follow this plan of action. As long as you understand that, there's nothing I can do about that. You have been warned, is sort of what it is. And it's like, and I don't usually say like, you need to get out. Like, I have in the past when patients who are just really bad about certain things, like, this isn't working out. It's usually when there's a trust issue that's been there. But what I find sometimes challenging is the worried well, is what they like to call it, which is when you have somebody who has this like vast plethora of symptoms, and then they come in and say, oh, I looked up at Google. Google says I have insert whatever obscure disease here. And then it's like, I want to hear your concerns. It's my job to work it up and figure out where we're going with this. Sometimes we come to a diagnosis. Sometimes we don't. Sometimes patients are willing to cooperate. Sometimes they won't. This is often where a specialist is really helpful. If they're convinced they have obscure disease here and, all their tests have been normal or negative or not supporting that or whatever, it's like, okay, maybe you should talk to the cardiologist or the pulmonologist or whatever ologist, so that they can tell you, if you think I don't know what I'm doing, or if you think I'm wrong, despite all the evidence I've provided to you. And that's often how I address patients too, is like, I'm like, look, I'll tell them why I don't think this is the problem, or why I think it is the problem, because of this, that, and the other. But sometimes patients just get a bee in their bonnet, and that's just how it's going to be. And then, you just do the best you can. But it is frustrating when they come in thinking that they know more about everything than I do. That's kind of like, okay, well then why are you here?
Chill, you have a question?
I do, and you sort of touched on it, Dr. Falls, about dismissing patients from the practice. I understand the concern as far as having an unvaccinated child, among newborns coming in for their, baby visits and such. But concerning adults, like, what if you have a patient and they won't quit smoking, or they're overweight and won't lose weight, or, I mean, they do other things, you say, but they just don't do those things. Like, do you agree
it's about
with
communication.
Push,
well, it's about communication. It's about saying, hey, I'd really like you to stop smoking, and that's, or whatever it is that you're doing. And it's working with the patient on that, because sometimes they're not ready, and so you have to get them ready. And it's interesting how when that therapeutic relationship has been established, when the trust has been established, when they see that I don't have anybody else's agenda being pushed except their own health, then they kind of go like, she's been nagging me for the last year and a half to stop smoking. I think I need to really start taking that seriously, because she's been helpful, or is listening to me, or whatever. And, so you just do the best you can. And you can't control everybody. You can just give the best advice you can. But it's that whole therapeutic relationship. And that's what I've always loved about primary care. It's you establish a relationship with somebody, the trust is developed. And then so now, it's, you understand that I'm not there to hurt you. I don't have any horse in this race except making sure that you live your best life.
Wow. So, I mean, addiction is a tough beast, for whatever kind of addiction. You guys have to deal with that, right? Uh-huh.
It is. There's a lot. There's a lot of ties, not always, but there's a lot of ties to mental health concerns, and tobacco use, especially in certain demographics in certain parts of the country. I think it's different. And then I think alcohol abuse disorder is much more prevalent than people will let on. I do think that a lot of people probably drink a little heavier than they're willing to let on about.
When it comes to drinking, that you always have to, I think I may have asked this in the past, fill out the form. How often do you drink? Like, someone who maybe socially drinks, a glass when you see your friends, but not, how do you answer that?
So I just want a rough idea in general.
Okay.
Like, do you have a couple drinks a month? Do you have a couple drinks a week? That's a lot different than if somebody's having a couple drinks every day, and before there was a bit more of a, just a general pattern of your alcohol use, but you do have people who binge drink, which is defined as a female having more than 4 or more drinks in a 24-hour period, or male having 5 or more drinks in a 24-hour period, and that's considered binge drinking. I know. And
wow, 4 shots.
Yeah. Well, see, that's the thing too. Is if you think about it, you have people who have an all-day barbecue, right? So they're out there getting started, they're starting to grill at 11:30, 12. Got the meat on the barbecue or whatever, let's have a beer. And then we sit down and eat a couple hours later, and then we have a couple more then. And then now we're sitting around the fire, chit-chatting, and now we have another beer or a shot or a glass of wine or whatever. And so technically you can go over that pretty easily. It's just a signal that there may be problems with alcohol use, There is no medically safe level of alcohol use. Alcohol is a carcinogen. Just have to throw it out there. It's just that there, in the past with, you should have a glass of wine. We think that's good for you and all that stuff. That's totally out the door. It's very old fashioned.
Wow. So I have this friend, every time I see her, she always has a bottle of champagne.
I know what friend you're talking about.
have to finish the bottle. I mean, is that binging?
Well, I mean, just because people do participate in binge drinking behavior, it doesn't necessarily mean it's an immediate huge threat to your health. I mean, if you have somebody who, like I was throwing that, all day barbecue thing out, as an example, if somebody does that twice a year and it's responsible with, I don't really know if my advice would be like, that's enough of alcohol to not be good for you. You got to do you, I'm not sitting there thinking I have to put this person in a detox program and, like we need to get intensive psychotherapy going. Like I'm thinking you just need some advice to know that that's not good for your health. It's kind of like, well, hey, ice cream isn't really good for you either. But if somebody said, Dr. Foz, you can never have ice cream again, I'd be really sad.
I think if you're drinking like that, though, you're not drinking it like twice a year. If you're having 5, 6 beers, 7, 8, because I think 4 is a pretty minimal for a person who's going to binge drink. But I don't.
I'd be on the floor at that point.
Auntie here says 5 shots is just appetizer.
Mm-hmm.
Like I don't drink, but I can have a shot of liquor if I'm around people. But there's no way I can drink 4 shots of liquor. I mean, that's just beyond my tolerance. So if you're drinking like that, I think you're drinking, several days like that.
Well, see, that's the thing too. Yeah, that gets back to the fact that I think that what alcohol use is underreported to us because they're hiding it. They don't want you to know or something. Auntie, did you have a question?
Well, not more of a comment. Is not to throw my generation under the bus, but millennials. We tend to a lot of our events that they tend to be very alcohol heavy. So a lot of us, and I wasn't kidding when I say 5 shots is an appetizer. That's like the beginning of the night. We're usually between maybe a night with friends, maybe around 6 or 7 bottles between us all. So yeah, it and it's underreported. I agree. It certainly is because when you think about it, it's like, wow, I just drank that much. Wow.
Yeah, I mean it's not. You'll have people who regularly polish off a bottle of wine every night with dinner, and they think that's not a big deal. And it's a lot.
Now I read somewhere that the Gen Z. And I don't know if Dr. Ray is kind of out and about. Dr. Ray is getting in their car. And I'll mute Dr. Ray. Yeah. The Gen Z, they are drinking less, which is affecting the restaurant business because they're saying that the young people are drinking, what do you call that? The non-alcoholic drink. So they'll just order one drink. Mocktails, that's it.
It's unfortunate for business that happens, right? I've been reading about distilleries that are shutting down. Microbreweries are having problems now where that was, craft beer was all the rage and now a lot of those places are struggling. There is, I get it, like from the business point of view, but I can't say from a health point of view that's not necessarily maybe a good thing.
But are you seeing that though with the younger people, your younger patients?
It's variable. I can't say for sure. They're telling me. I do see there's been a trend with like dry Januaries, and all that stuff. Like, oh yeah, I'm not drinking this month. And then I'm kind of looking at them like, well, how much were you drinking before? You told me that you were having, 2 drinks a week and now all of a sudden you're on dry January. Well, what? Is it just like, are you just cutting out all sugars and all refined carbs and alcohol and all red meat and all those things just to be healthy? Or did we have something else going on? And then I can't know, there's no way to know unless they tell you.
Go ahead, Chill.
I just wonder if maybe what they drink has changed, not just mocktails, but there's so many like canned alcoholic drinks, hard lemonade, things like that.
White Claw.
It's like a lot of drunk people out there. So maybe they're not drinking whiskey or beer, but I think people are still drinking. So I don't quite get that one.
I'm seeing them. I see on TV they're drinking Coors. I mean, my dad drank that in the 80s.
I'm getting a stomachache just talking about all this stuff.
I mean, okay, so let me kind of, are you seeing
I think they're still
maybe...
drinking.
Okay.
I think they're just drinking more at home. I think, like, drinking wine at home has been more of a thing.
Oh.
It's cheaper.
It is. And that's the other thing, too, is, like, how much is this the economy? Like, you know, if you go out and each drink is, like, $22.
Right.
That's true. That's true.
I think they're still drinking, personally. Cause,
yeah.
Well, they share their Netflix account with their parents.
Right. Yeah, but I think it's happening more at home, because even myself and my sister and my cousin and myself went to a football game, and the cost of the drinks, you know, at games are really expensive. So we made sure to get some stuff beforehand, and then we only got one drink there. So I think cost is definitely an issue, because the economy is terrible. And even when we'll go out to eat at dinner sometimes, and we'll be like, oh, let's get a drink, and then I'll look, and it's, cocktails are almost $20. So then I'm just like, no, I'll just get water, and I'll go get a glass of wine at home.
That's true. Yeah. That's why you got to invite this other friend of ours that just brings champagne with her all the time, right?
Right.
They say champagne has the least sugar.
Right, but that's drinking at home.
That's true.
But that's still drinking at home. Imagine if we bought that champagne per glass at the restaurant. That would be, quadruple the price.
That's true. I chill. I'm sorry. I think I cut you off. What did you say?
It's okay. I remember going to an Italian restaurant. It wasn't high end, but I mean, it wasn't like a McDonald's type restaurant either. But I ordered a glass of wine, just white wine, while we were waiting for our table. And so when my friends got there, the guy who served me said, "You want to settle up over here, or you want to put it on your dinner tab?" I say, "No, I'll settle here because I'm not having another drink." That glass of wine was $30. I'm like,
oh wow,
I could have.
Was it?
I'm sorry, 30 USD.
That sounds like a good glass of wine.
Good. I mean, I'm not a wine connoisseur, but I didn't taste it and like, wow, this wine is pretty. I've had wine before. I'm like, this wine is fantastic. No, it wasn't that good.
I totally feel that. I totally feel that too, because like I don't really like alcohol. And so I'm like, you made me pay $25 for a drink that I think tastes like detergent and cleanser.
Right.
It's not even good.
Well, now I have a follow-up question. We're talking about alcohol. Are you seeing maybe more people are taking like other drugs as opposed to alcohol?
I would say that the trend has been towards psychedelics. It's the rise of psychedelics and not necessarily new ones. Yeah. So I have had quite young patients they experiment with LSD, and I'm like,
LSD?
What? Yeah.
That's
LSD. Yeah. Mushrooms. I mean, there's always the ecstasy stuff. That's not what I'm talking about. I'm like, LSD? Like, really? So, yeah.
And are you
seeing... That's way before my time. I'm like, what?
Are you seeing, what about like ketamine? I hear that a lot.
No.
Okay.
No, I can't. So esketamine is FDA approved for depression. It's like nasal ketamine, but I think you have to have a special license to do that or special training, and there's all kinds of stuff associated with like that I feel is something that should absolutely be left to a psychiatrist. Like that's not, if you're so bad that you need to be on that, and some people are, like, you should definitely be under the care of a specialist to help you with that. I don't have any experience with that.
Wow. So are you
having said that, I don't know. I mean, people are not 100% truthful, they tell you one thing and they do another, and they hide stuff from I mean, I feel like I'm everybody's mom, and they're, it's just, they're not always honest, and so, which is frustrating because sometimes once they understand that you're not out to hurt them and you're not out to do anything to them and that you're not there to judge them and all those other things that make people fearful of opening up, then they'll tell you stuff and you're looking at them like, why didn't you tell me this before? This explains X, Y, or Z, or like, I just wish I'd known that because then I could give you better guidance.
So are you finding this from like blood tests? Or are they just telling you during a conversation?
No, they'll just tell you. Like, and some people are, I mean, a lot of patients are, when you meet them, like it's part of, your initial intake, what meds do you take? What's your medical history? What's your surgical history? What's your social history? Do you smoke? Do you drink? Do you do drugs? Do you use, do you do drugs? Do you shoot up? Do you use inhalants or whippets? Do you smoke marijuana? Like, what exactly do you, what kind of work do you do? That type of stuff. Do you have kids? Are you married? What's the situation? I need to know your sexual habits and all those things.
Wow. So is it, now I'm just asking from a personal point of view, when I do tests or when I see my doctor, kind of like, okay, I'll eat whatever I want so that I'll test bad and then it just gets better from there. Or do people, some people that are like, oh no, I gotta eat good if I'm gonna see my doctor. What are your thoughts of that?
Well, I mean, there's some things that you can manipulate and some things you can't because they take a long time to evolve, right? Mm-hmm. So if somebody eats only, chicken, spinach, acorns, rocks, and concrete for months and months and months, and then they come in the night before, they've had, only ice cream and cake and cookies and whatever sweets or bad stuff, and then I do a blood test, like your A1C won't change much, your hemoglobin A1C, which measures the average of your sugars in the last 3 months. It takes about 3 months to evolve in the average situation. But your fasting sugar absolutely can be affected sometimes. So, I mean, you can manipulate some of it and then you can not manipulate some of it. Like cholesterol panels generally take a couple months to have any significant changes for some of it.
Good to hear that, because I want to play this back to my dad. All right, I'm going to change subject. I have this question. What is the difference between MRI and a CT scan?
Oh, well, an MRI uses magnets basically to get a picture of what's going on. A CT scan uses X-ray, so penetrating radiation. They look at different things, and some tests are better for certain things. Some of it also has a lot to do with what you're trying to diagnose and the medical history of somebody. So if somebody has like metal implants that are not titanium, or it might have a history of like metal fragments into the eye, they're not a candidate for MRI.
Okay. So if you have like
or except in like, so you have some patients who'll have like a defibrillator or they'll have like a pacer and stuff. They can have MRIs done, but they have to be done in certain academic centers where they can do something. These are things that I don't have any experience with.
Got it. Okay.
They're not commonly dealt with.
Like a 79.
Yeah, there are certain modalities that we use to diagnose certain other disorders. And for example, like if someone was pregnant and needed to get a imaging study done, then an MRI would be preferential to the CT scan based on the amount of radiation that's given.
Okay.
Or like ultrasound, which has no radiation either.
Okay. So if you have like a 79-year-old, man, like an old senior citizen, and kind of just said they got an MRI, and then later on they said, no, it's not an MRI, it's actually a CT scan. Like,
it depends on what they were looking for, I guess. That's what part of the body, what was the disease that we're looking for, or what was the concern. So people automatically make the assumption that MRI is superior, and it's not necessarily superior. It depends on what we're looking at.
She's talking about your president, okay? Oh, I didn't have had a CT. because people were saying, "Oh, you had an MRI. Well, what's wrong with you? You know, that you would have such a study."
Well, indications for it depends. Like if somebody has if you have somebody who's older and they have chest pains and part of the workup includes getting theoretically up to getting a CT scan to make sure they don't have an aneurysm of the aorta, and so CT is the preferred modality for that. And that just because you have it done, it may be negative. Like, okay, well that's not what you have. You have chest pain because you have heartburn. Here's your omeprazole or whatever, and bye. It's just because a study is done, to be fair, just because a study is done doesn't necessarily mean there's something terribly wrong. We're just trying to exclude something terribly wrong.
Except something is terribly wrong with that.
Why would he lie? Why would a guy like him lie?
Okay, are we really getting into that?
I'm trying to understand. From a non-medical person.
It's different from a public figure, especially the president, because we're supposed to be privy to the president's medical records.
Oh,
which
really?
I think in some ways, which I think in some ways is a bit of, but that's my understanding. Generally, I would say I don't know if we're supposed to. I don't know if this is written into federal law somewhere, which I doubt. But I mean, in the past, I think presidents have been more open about their medical records, right? Like they're supposed to be open about it just to prove that they're in, the appropriate health to lead the nation. There's many reasons why so they're both things where you lay in a machine and pictures are taken. So
okay.
I can understand where somebody may not necessarily know the difference. The procedure themselves are very different. An MRI is loud and takes longer. A CT scan takes a minute, and it's quiet. It's the buzzing of the table that you're moving on, But, there are reasons why CTs are done. I was wondering if they did, I had read similar comments, right? And I'm not, I don't.
Yeah, we're just
know.
speculating.
Right. But I was wondering if they were doing a CT coronary calcium score, which is, I think not something I would necessarily do in this age group, to be honest, but that's just a way to look at the burden of calcification in the coronary arteries, so the arteries that actually feed the heart themselves. And it can give you an idea as to somebody's cardiovascular, can be one piece of a puzzle that can be used to give you an idea as to somebody's cardiovascular risk. I wouldn't imagine that would be done in somebody of that age group. They also now we're doing a lot of CT angiography, which is another way to get an idea as to the vasculature of the heart itself. That's considered non-invasive. I don't know. Like I said, aneurysm is what I would think of in his age group. Or are they making sure that he didn't have an aneurysm somewhere that could be getting ready to rupture?
Or looking for signs of dementia.
Oh, how does that work in dementia?
Well, there are signs
brain
on
volume.
The MRIs. Yeah, the volume of the brain, and I'm not a radiologist, so I have no idea, but I know that you can do these studies to look for signs of Alzheimer's, dementia, other types of brain issues.
I would imagine that MRI is a better test for that, so I wouldn't think that CT would be. So that's why I'm not thinking it was that. I don't know if they think that he had an urgent situation, it would be, if you have bleeding on the brain and things like that. But those are things that are usually acute, like suddenly there's a problem, as opposed to indolent kind of, Grandpa's getting a little goofy, maybe we should look,
A lot of people
more than goofy
saying that he does have frontal temporal dementia, and on the internet he's exhibiting signs. And I mean, these are medical people saying this, so of course he's not the kind of person that's completely honest about what's going on. So it is what it is.
What's the machine where they inject like something like a color in your blood vessel or something like that.
And so that you might be referring to contrast.
Contrast, yeah.
So contrast agents there's oral contrast and there's intravenous contrast. And they're given prior to studies to help highlight certain things. So they're often used to highlight like vasculature or tumors, if they're, so contrast agents are often used to look for certain things. And then if you're talking about injections of other stuff for diagnostic purposes, there's 1,000 things, but another commonly, you might be talking about angiogram, where like a coronary catheterization is an angiogram where you get dye injected. There's a catheter that's threaded in through. Commonly now it's the wrist. Previously it was the groin, like the thigh fold.
Wait, it's the wrist now?
Oh,
yeah,
wow.
The wrist, and they snake it up through to your actually outside of the heart arteries, and then they squirt dye as they take pictures of your heart, and that's the gold standard for visualizing the anatomy of the coronary arteries.
Wow.
So you might be talking about an angiogram is another reason when they use contrast agent. So there's a lot of reasons why. And contrast is, to be fair, is not always what you want to do because there is potential risk to using contrast agents, particularly in certain populations.
What do you mean?
So with the use of certain medications, you want to be careful with contrast agents. Contrast agents can also trigger pretty significant allergy type reactions, and it can be rough on the kidneys. Oh. So if you have like a healthy person, who needs contrast for whatever, it's not much of a risk. But if you have somebody who is got certain medical conditions, diabetes, hypertension, or if they have pre-existing decreased function in their kidney, then you want to be cautious or avoid contrast agents.
Okay.
So it's not always better to do contrast. That's what I'm afraid people take away from these things. Like, oh, well, they said that, MRI is better, so I want an MRI. And, oh, well, I want it with contrast. It's not better or worse. It's risk benefit, and sometimes there's no benefit. So why are you doing it?
Okay. Well, yeah, you mentioned allergies, and I'm hearing a lot of people waking up to allergies. I don't know, the change of weather because it's colder. Is this common?
Allergies are not. If you're talking about like hay fever, seasonal allergies, there's seasonal predilections depending on what people are allergic to. So commonly you hear about this in the spring, a hay fever in the spring because there's so many, and depending on where, and depends on where you live too, because there's also regional problems with this, right? If you live someplace where there's clear 4 seasons, like, upstate New York or something, you might have more seasonal things than if you live in, somewhere in California where you have a more temperate climate. So it depends. You can also have, so weather changes may or may not be related to that. There's also a condition called non-allergic rhinitis, which is all of the symptoms related to allergies, but you're not actually allergic to anything. And it can cause similar symptoms, and that's temperature responsive as well. And the funny thing is determining if you have allergic or non-allergic rhinitis isn't always all that important in the average person because it's treated the same way. Oh. It only becomes an issue if we're thinking about immunotherapy with allergy shots and things like that.
So as it's getting colder, people are sneezing and coughing, and
they probably have colds. It's more like you're more likely to get a viral illness when we're, just kind of like some of the lessons from the COVID pandemic, right? When we all congregate indoors, we're more likely to, because we're close together in colder weather, we're more likely to transmit viruses, and then, and not just flu and not just COVID, but just plain old viruses.
But is there like a telltale sign if someone goes, oh, no, don't worry, it's just allergies? Like, can I? Is there...
Not always. Not always. If you have a fever, then that's not allergy.
Uh-huh.
and that's not, and that's the other thing too, right? The definition of fever. This is sometimes where I want to strangle people. You have a fever. How are you defining a fever? So we define a fever as a temperature of 38 degrees centigrade or higher, which is 100.4 or higher.
Okay.
So if you tell me that you have a fever and you're coming in, I had a fever. Okay, how high was it? It's 99.7. That's not a fever.
Okay.
Even if you get on your horse and tell me, but I am always 97.6. I don't care. That's still not a fever. There is variation. That whole 98.6 is normal body temperature. That's not really 100% true.
Okay.
But I'm not upset if you're running at 99.7 unless you're exhibiting signs of severe illness. Then I'm like, any temperature change at that point is much more concerning. You know, if your heart rate's 120 and you look terrible, 99.9 is more worrisome now, or even low temperatures, right? So if you have somebody who's on the verge of sepsis, they actually might run a low body temperature. But to get back to the original question, if you have things like a fever, it is not likely to be allergy in nature. Sometimes it's hard to tell. Classic, upper respiratory infection is sore throat, runny nose, mild cough, body aches, and or fatigue, and or some malaise, like I just don't feel as good as I normally do. But you can have people who have milder colds that just have a lot of nasal congestion and cough without a fever, without body aches, things like that. So unfortunately, it's a whole bunch of diagnostic data to, it's like that's when I interview a patient, right? Like, okay, what are your symptoms? How long have they been going on? If you tell me that you've been feeling, nasal congestion and cough for 3 weeks, okay, that's not a cold. That could be a consequence of the cold, but you are not currently infected with a cold.
Good to know. So if I go to dinner and someone has a box of Kleenex with them and they're I'm just having allergy, at what point do I raise my eyebrows and go?
I mean, it's possible.
Put on a mask.
Yeah, I mean, it depends on I think there's a lot more concern about that nowadays than pre-pandemic. Mm-hmm. Like, I think in the past, go back to 2016, would you have cared? Probably not. It's more like, oh, great, now I'm sick. It's like, oh, that would be it. Now
I would have cared. I can't afford a day off. But okay, that's good to know. Anyone here have a question before we end this? And if there's no question, I am going to play something here that I want to get your feedback. And I know Dr. Ray is in the car, so let's see if this is going to work.
I'm still here.
All right, cool. Let me see if you guys hear this. I follow this channel on IG.
Of 10, but they're also laughing and asking if the cafeteria is still open.
10 out of 10, pain does not laugh. That's not suffering. That's hunger with confidence.
Tita, so if the patient keeps calling every 5 minutes and nothing's actually wrong, do we, document that?
You document facts. The fact is they're bored. And the other fact, you are not their Netflix. Answer once, be kind, then keep walking.
Tita, patient's pain is 10 out of 10. Vitals are fine, labs are fine, CT's fine too. But the family is escalating.
That's not a medical emergency. That's an emotional one. You treat the pain, I'll treat the audience.
Tita, quick question. If the patient says they're dying, but they're also asking for a turkey sandwich, do we escalate or?
If they can chew, they are not dying. Give the sandwich. Save the drama for later.
Ay nako, they singing karaoke in the patient's room? What's next? Fiesta with lechon?
Yes.
Well, there is a lot of drama in medicine that's not, there's people who are dramatic. That's also the case. But yeah, if you are saying you're dying, but you are eating or want to eat a turkey sandwich, you're probably not really dying.
All right. Well, that concludes this episode of Between Doctors and Friends. you.